As usual, if everyone could make sure that their name appears as we know you so that it doesn't just say Jay's iPhone or something like that. Make sure we can see your name so we can take roll. This is our agenda for today. We'll have a report from Dr. Bard on the baseline report about the data for this innovation project, focusing particularly on health equity. Dr. Fleming, Tabitha Fleming, is going to present on substance use screening, a presentation that she and I worked on together. Then we're going to hear from you on your PDSAs, the current ones, and telling your story. As we've been saying in the rounding calls, this gives us an opportunity to hear in some more detail and richness about your experience so far. And then after we conclude that, we'll break for lunch. And then at 12:30, we're going to come back for some Unitas training. And one of the things that Kayla Woodbury is going to talk about there is custom forms. And that's where we're going to be collecting much of our data for your PDSAs and for our evaluation. After a break, then we'll have breakout rooms to create a second PDSA that will go into effect end of this year, first of next year. That's been a little bit up in there, but we'll iron it out. And then after you've come up with that, we'll get back together and go through and have everybody summarize what they're going to do for their second PDSA. And then we have Dr. Bard making final comments, but that'll actually be me today because he and Tabitha need to be elsewhere, that they were double booked. So Dr. Bard, would you like to start, or do you want to wait just a couple of minutes?
I don't know. What do you think? How many? Maybe that's a good question for.
Well, we've got 41 people here. I think we pretty much have our group. That's pretty typical number for us to get at this
Okay.
point.
Can you hear me? Okay.
Yes.
I'm actually going to turn my audio up just a tad. Okay. Well, welcome everyone, and thanks for attending. So Lisa has covered the agenda quite well. We can skip right to this baseline report for health equity data. Those of you that have been on monthly calls over the last 6 months have seen various versions of some of the data I'm about to represent. We've added a few new elements, and actually we have some additional data to present today that we haven't shown you yet, all of which are related to the first four objectives of the innovation project that funds the use of the Unitas application, the implementation phase of that, as well as the evaluation that's ongoing in the background. I'm just quickly going to cover these objectives. You see them in front of you, and then we're going to talk about some of the data, historic data that's been logged in your ETO system and what it has to say about the typical performance to date. So at the very top of the list, these are what we often refer to shorthand as incoming referrals. So the hope is that through the use of Unitas and through this concentrated focus and effort on referral processes, that we see an increase in the incoming referrals to home visiting by 25% annually from the designated pilot referral network. So that network consists of 3 organizations, as you're well aware. Our peers at LASSO, Sooner Start, and PCAP, all of whom are on today as well. So, our hope from the very beginning was that if we could stand up this care coordination portal system, that it wouldn't only facilitate the outgoing referrals to those referral network partners, but that in return or in kind, they would feel compelled to use that same system to send referrals your way. And we had some anecdotal evidence that there were many families coming through their doors that could benefit from home visiting services. So it's an aim that we wanted to keep track of. You'll notice that the percentages are a bit asymmetric when you compare objective 1 and objective 2. Um, the referral network partners are, this is a heavy lift for them to be a part of this project, with certainly some funding that's coming in to support that effort, but the support that they receive is also asymmetric. So that's partially why the percentages are not equivalent. Okay, second objective, increase the number of outgoing referrals by 30% annually to those same community agencies. And part of the emphasis of this funding mechanism was to facilitate a return to normalcy, if you were, or to the status quo prior to the beginning of the pandemic, recognizing that a lot of our referral systems and certainly the lives of the families that we serve were greatly disrupted by the pandemic. What types of system innovations can be introduced that could facilitate a rapid recovery back to where we were prior to the pandemic, and perhaps even exceed those earlier benchmarks. Third objective, and one of the most exciting opportunities and features of the United system, is this close the loop, as we called it, ability to communicate with one another a lot more readily, a lot more efficiently than we have in the past. So we'll be monitoring that closely. I don't have data for you on this now because it's not data that we've been able to historically log well. You'll see we made some meager attempts in just a moment of trying to identify cases that were referred out from home visiting to agencies like LASSO, PCAP, and Sooner Start. And I say like because for LASSO and for PCAP, a lot of you, these are newer relationships. So there were very minimal, if any, prior history of outgoing referrals to those two systems. Sooner Start is a long-term partner for all of you. And you'll be able to see from the data we present on Objective 3 that there is certainly room for improvement in terms of closing the loop. And it may just simply be workflow related and the ability to document this more efficiently than we have in the past. So I'll quickly cover utilization of services when there's evidence of an outgoing referral to support legal aid concerns, substance use services, or early intervention. All right, and then finally, this fourth objective is to increase the retention of clients. This is sort of the grandiose downstream benefit of all of these PDSAs that you've developed and of all of the day-to-day work in the United system. Our hope is that by experiencing more outgoing and incoming referrals, that more families are served and benefit from the community coordination that Unitas enables. So I'll represent some of the retention data, historic retention data from the 3 models of home visiting that you all administer. And then we'll talk about sort of a rewrite of the hypothesis or the evaluated goal for that particular objective. More on that in a minute. Okay, next slide. So starting at the top with Objective 1, these are those incoming referrals to home visiting, and we're going to look at them one by one for early intervention or Sooner Start, legal aid services, and substance use. These are the numbers for Sooner Start. Here again, I think the bar is probably going to be pretty low, and it's not perhaps because you haven't experienced incoming referrals from these types of agencies historically. It could just be the inability or the difficulty of accurately reflecting that in the old legacy system, in the old ETO system. We went searching and we're a little bit surprised, interested to hear your feedback in how few referrals had a documented source that we could reasonably link back to Sooner Start. So this is a busy slide. Let me walk you through it, and then the format gets repeated for several slides here. In the top right-hand corner, the blue line that you see there, those are the real rates of referral monthly, going all the way back to, ooh, Andrew, I may need some help here,
August of 2016.
August of 2016. Thank you. So starting August of 2016, these are the data we found in ETO, sorry. And for the PAT program, at least, we didn't have any documented evidence of an incoming referral coming from Sooner Start. Pretty confident that that's probably not entirely a reflection of the real world, but at least in terms of documentation, we couldn't find it. Now, if it was buried in a note, which is likely in a free text field where you could type anything you want, we did not search those, right? That's very difficult to harmonize or to pull together, as you might imagine. So we relied on the structured fields, as they're called, where you had to sort of point and click options. And we did find some where an option existed for Sooner Start. But as you can see here for PAT, going all the way back to August of 2016, we're not finding any. Okay, so that makes the benchmark or the goal of Objective 1 a little tricky. And I think the goal that's reflected here is an optimistic and maybe even an overachiever's attitude of where we're going to end up. We're not quite sure where to put that yet, so this is certainly open for discussion with this group, and perhaps in the next monthly meeting or two, we can come to an agreement on where that ought to lie. But no doubt, we're hoping it's higher than 0, and the actual benchmark we'd like to reach, though, is sort of again up for discussion. Okay, bottom left-hand corner now. Same data, but we're looking at the safe care programs. You can see a little bit of a blip there in looks like 2022 or maybe 2023. So we've had at least one referral come to home visiting from Sooner Start, but it looks like it might only be one. And yet again, that's difficult to rely on a single referral and then set a benchmark of improvement. So still open for discussion as to where that goal ought to fall. You probably already have guessed it, but your bottom right-hand corner now, same data, but C1, not finding any here. No surprise, because to be referred to C1, you have to be pregnant with your first-time birth. So this one is not going to move, no matter how well we document. And I think C1, you're just simply going to be excused for the Sooner Start version of Objective 1, unless I'm missing something there. But it's hard for me to imagine how Sooner Start would be sending referrals your way when you're enrolling first-time pregnant mothers. Next slide. Still on Objective 1, we're just switching the types of referral sources. So now we're looking at legal-related referral sources. There were not a ton of options here. Andrew, if helpful, and if you can remember it, feel free to yell out the exact values that were selected for this. I remember lawyer was one of them.
I actually put them in the notes underneath the slide, but yeah, one of the values was lawyer, and another one was grandmother went to LCDA looking for legal advice.
Okay.
It's worth mentioning that for all of these incoming referrals, we did have to look at unstructured data. We had to look at free text that people just typed in, and we just had to come up with some way of identifying strings of text that we thought that seemed to be related to early intervention, Sooner Start, screening. And that's I think you may have said we had structured data for this. We had structured data for outgoing referrals, but for incoming, we just had free text and had to do our best to make sense of free text data.
Oh, okay. I had forgotten that piece of information. That's good to note. So we did actually explore some of those free text fields, it sounds like, searching for terms that we thought were related to each of these topics. Okay, so lawyer, and then one other very specific referral coming to LCDA that seemed to have some legal issues. And that's the one and only green line blip that you see there in the top right-hand corner, I suppose. Yes, it must be. And again, we're not quite sure where the goal ought to fall, but somewhere between 0 and 1 seems reasonable. I'm not going to belabor this point much longer. How about next slide? Substance use. I don't think it changes terribly much. Get a little bit of activity in the bottom left-hand corner for safe care in the early days, but having a hard time finding or linking referrals back to a substance use provider really since 2018. Before we move on to Objective 2, I'm going to open the floor for comment, discussion. Do these data surprise you? Are there other places we ought to look to try to link referrals that you receive back to these types of community agencies?
I think that sounds right. I mean, and I don't know if we have ever labeled them. I mean, thinking through it, I mean, when you label who sent you that referral, but I don't think, you know, if we have ever received just from them calling us, I have this child, I don't think so. So it sounds right in my area.
Thanks, Pat. Yeah, and it makes sense. Yeah, I mean, it hasn't been something we really tracked. I imagine that you haven't tracked as a program historically. So, although we'd love to have good baseline data to determine what's an effective or realistic goal for the future.
I think the only place that you can find, you know, where this referral is coming from, and maybe it was not specifically saying Sooner Start, because maybe it could be a therapist, is whenever you do the combined screening and then you know where this referral is coming from. That's when you describe if it's a walk-in or if it was referred by another agency. That's where you will know where these referrals are coming from.
Yeah, and Andrew, correct me if I'm wrong, but I think that is where the data is coming from, is that combined screening form.
This is coming from the demographics touch point. We have looked at notes, the STARS notes and screening. We've grabbed that data. I don't know if we've done much with it. The data from these graphs comes from one of 3 variables in the demographics touch point that asks about the name of the referral source in a couple different ways.
Okay, well then that is another potential avenue we ought to pursue, the combined screening form.
David,
Yeah.
this is Susie. I will say in the past, I don't know if it's still like this or not. I have had affiliates report to me the difficulty of getting referrals from a county health department in general. Like unless the service resides in that health department, a lot of times they won't refer to the outside contractors. Now, again, that was kind of a historical perspective. I don't know if it's still that prevalent like it used to be, but that was also an issue that maybe might help us understand about the referrals coming in.
So am I understanding correctly, Susie, you're saying that sometimes the referral comes to the county health department first, and then they funnel it to a program, and when it gets funneled, that information of referral source may be lost?
Well, I guess what I'm saying is, you know, we're talking about we're not receiving referrals from Sooner Start. And typically in the past, and those of you who are on the call from the affiliates that kind of agree with me, let me know that they didn't refer outside of any services that weren't in that county health department.
Oh, I see. Okay.
Does that make sense?
Yes. Yeah. So
I just had, yeah, in the past, I've had reports from different affiliates that says, I can't seem to get an in with this county health department to get referrals. And I've actually tried to ask specific county health departments, can we do some tabling, or can we, and that was a no-go. I specifically remember Northwest. I know that's a state funded, which isn't on this call, but that was a big issue. So anyway, that might be a piece of the puzzle to help us understand why maybe those referrals aren't happening.
That's great. Thanks, Susie. And we'll check in with the liaisons for Sooner Start, LASSO, and PCAP. Again, for LASSO and PCAP, I think it's probably just the newness of the relationship and the knowledge about the program that have probably been a deterrent historically. But for Sooner Start, we'll do some digging there on the other side of this and see what reasons they might come up with too.
And
Okay.
Dr. Fun, it's true that Dr. Bart, that it's true that an ETO is called view edit screen. I mean, I just keep calling it combined screening, but it's in the view edit screen and ETO.
View edit screen. Okay, Andrew, did you get that? We
Yes.
have that data, I know we do, so we'll have to go back and maybe you and I can look at that together. For sake of time, I want to move on to objective 2 real quick. And these are data that you've seen before, although we've added a new line to it. So that red line, and I didn't explain this well because we didn't have that many to talk about previously, but let me take some time here to explain the green, the blue, and the red lines that you see in front of you. Top right-hand corner, again, PAT, bottom left-hand safe care, bottom right-hand C1. So at the top right-hand corner for PAT, just for sake of example here, the blue line is a yearly average. And we went back and aligned the years with the start of this PDSA that is about to happen. So when Andrew said the data starts in August of 2016, you may have thought, like I did initially, well, that's a strange place to start. We did that intentionally so that we could have from August 2016 to July 2017 as the first year example of average performance, and then every year thereafter. So the blue line is the average yearly performance from an August date to the following July date. The green line, you can guess by all of the jumping up and down, is the real data. So how many referrals are coming in for this model among the Learning Collaborative sites here, so just among your groups, monthly from August 2016 all the way up to present day. And then finally, the red line that you see, you'll notice that it too is a yearly average essentially, is this benchmark that we had set for ourselves in the grant proposal of a 30% increase. We decided to look at a 30% increase relative to the prior year's performance. So you can see that that's going to move around a bit naturally from year to year just based on performance. And the very far right end of that red line is one that you're going to want to key in on, because that is effectively the goal over this next year for this type of referral. So to put some numbers with it for PAT, we're looking at annual performance, real average performance here, and the 2022-2023 year was roughly around 4.5 referrals per month that we're heading to, and now we're looking at sooner start. So the goal for next year, if we were to get a 30% increase with this utilization of the United system and the focus of CQI projects on sooner start referrals, is to have slightly over 5 referrals per month on average. Bottom left-hand corner for Safe Care, looks like the average last year was just under 1 referral per month. So the goal here is roughly 1 referral per month for next year, 30% increase over last year's performance. C1 was very similar, so it's also hovering around 1 referral per month on average, and so slightly higher than that now that we're using the United system. Do those numbers surprise anyone real quick? So obviously there are some big program differences there, but that probably speaks to the population served more than anything else.
We also can see for PAT and C1 a dip with the pandemic.
Yeah, definitely a dip for the pandemic, and a lot of that is just the shrinkage of clients served as the workforce was deployed elsewhere to address directly some of the pandemic concerns. Okay, not your last time to weigh in on these issues. We can have ongoing discussions in our rounding calls and in our monthly calls. Here are the data for legal services. And because the relationship with LASSO is relatively new, we did expand that topic a little bit, trying to also look at referrals that went out for domestic violence or immigration issues, so not necessarily directly to LASSO, or even a referral that went out where it was clear to us it was a legal concern. So even with that expanded definition, you can see that the monthly rates are relatively low. You've seen these data before. I have to point out, though, as we were looking at the goals this time around, we were shocked, or not shocked, but we were all caught by the spike that we see in all 3 programs around the end of the year of 2022. And so I don't know, Lisa, if you can kind of circle those, but for the top right-hand corner, those few dots that we see, these were LASSO referrals that jumped all about the same time for all three programs. And we're not giving it too much deep thought. I mean, it cannot, we would think, be a coincidence that that was around the time LASSO had presented on a monthly call for us. Being the good stewards of the clientele that you serve, you reacted to that, it would seem, and we saw a flurry of referrals to that particular program. So one issue that causes as we set this goal is that if we look back at last year's performance, it's now skewed a bit by actually being a part of this grant, being a part of this innovation project, even before Unite Us went live. So I think we're going to alter this figure so that the jump is actually relative to the performance 2 years ago and not last year, because it seems a bit unfair that now that we've introduced these two programs that we judge your performance based on those initial spikes. Okay, let's move on to substance use. And I think you've seen these data before. We have an expanded definition for referrals that are heading out to substance use. PCAP is a brand new program, so we didn't have minimal, if any, referrals to PCAP yet to base this historic data on. So these are other types of community services that existed prior. And you can see that all three programs, the rate of referral is relatively low at certain points in time. PAT, you're referring actually more than the other two on average per month. And you can see where that 30% increase places each program. So a slight increase that we hope exists now due to the advent of the United system. The bottom right-hand corner, C1, that's just a glitch there. We're going to fix that. So we had set this minimum of 1 a month, but we really want it when there's real data to base for the historic count there. We want that 30% increase to be reflective on the prior performance. So we will alter that goal. It should be closer to, probably half a referral a month on average. Next slide. Okay, objective 3, this is the close the loop. So of the referrals that we see that are going out for these types of services, how often do we see documented receipt or utilization of that service? And I know we're looking at the referral tracking form for this data. Andrew, correct me if I'm wrong, but I think we're also looking at the ASQ form now, at least for the Sooner Start data.
For Sooner Start, yes, these are clients that are have been referred and are using a referral. Also, they have to have been identified as being below a cutoff on the ASQ. That's true of Sooner Start. I didn't bother doing that filtering down to those that were below an ASQ for referrals to legal services or substance services, because it just seemed like a different outcome.
So if we found in the referral tracking form or those follow-up referral tracking forms that the service was utilized, we went ahead and credited that family as receiving the service. And these are the percentages of the referrals that went out that had that type of indication. So you can see that it's relatively low for most of the months, with one exception in this case for early 2020. I'm sorry, these are annual rates, my bad. So these are annual rates, and you can see that in 2020, all of these referrals received services, but the size of the dot you see there's relatively small, so there were probably very few of those. So room for improvement here. We did not set a benchmark for this one because we knew historically we didn't have great data to link to. So what we're really planning to do is more of a descriptive evaluation of objective 3. How many of these referrals that go out do we see a utilization of the service? And we're also really honing in on the timing of that service receipt. And we're interested to see if there's an increase over time as your programs get more familiar and as the referral network partners get more familiar with the Unite Us system and the workflow that is involved there. Do we see those time lapses between when the referral went out and when the service is received decrease over time? But for what it's worth, here's your sooner start data utilization solely based on what we find in the referral tracking form and in the ASQ form of ETO. Next slide shows you what we see in the referral tracking form for legal aid services. Each line now represents a different program. Sorry, I didn't cover that. Red line is C1, green line is PAT, blue line is Safe Care. Okay, and then the next one would be substance use. And finally, objective 4. We, the evaluation team, needs to do a little bit of work on this particular benchmark or goal. And I'm just resharing data that we've seen previously, but I think this is really promising, a bit unexpected, but promising. We're really interested in segmenting the populations that you serve by social needs that have been documented in your ETO system. So we have 4 of those in particular that we're paying close attention to. This one recognizes families where you have identified a financial need, and if they're in the green bar, they were referred to a service. If they're in the blue bar, they were referred to a service, and there's documentation of receipt of that service. If they're in the red bar, it's essentially everyone else. So no identified need, no referral to this type of service. And these are retention counts. The top graph that you see, or the top set of bar graphs that you see are, oh, I may need help here. What is that? Oh, that's the pre-COVID data. And on the left-hand side, you get 3-month retention. On the right-hand side, you get 6-month retention. So those are the 2 markers we're paying attention to for retention. So just to walk you through one of these at the top, this is pre-COVID data for, which model are we looking at here?
Andrew?
I'm sorry, what was the question? Which
home visiting model?
Oh, good shout. I'm not sure I've broken this one up by model.
I didn't think you had. We can check.
Okay, so these may be.
Yeah, I think this is everyone.
All 3 models together then. You can see that for those with no identified need, the retention rate is lower for 3-month than for 6-month than those that had a referral and those that had a referral and utilized those services. So we think that this is promising data, and that if we can identify more families with these needs and get them referred to services, we ought to see a boost in the overall retention rate. So that's sort of the rewrite of the objective here for this 4th objective. I think we're going to focus more on overall retention of the program and try to link it back to the number of families being referred out to services and the number of families receiving those services. This is financial assistance, but we see basically the same pattern as we move on to, help me with the next one, food assistance. You see that same staircase. The red bar is always lower than the green and the blue. Green and the blue tend to be similar. And then next slide is housing assistance. And finally, transportation assistance. So those 4 types of social needs were readily available to us in the legacy ETO system. We're going to continue to monitor those closely. If you have ideas on other types of social needs that you log, that you're interested in us tracking, please let us know. Okay, I'm over time, so I'm going to cede the podium here, the virtual podium, to our colleague and co-lead here, Tabitha. She on, Lisa?
Yes.
Okay, Dr. Fleming, take it away. We're going to talk about current PDSAs for a moment.
Wayne, so before we jump into telling your story, I'm going to go through a brief presentation on substance use screening. Let me get that. Thank you, Lisa, for handing over the share screen. Let's see. Everyone seeing that okay? Okay, fantastic. I'd be remiss to not acknowledge that Dr. Deshay played a very large part in putting together this presentation. And I know in the last few monthly calls, we've been asking you all questions about substance use and what screening approaches you are using within your agencies. So we wanted to present to you on this topic and cover a few things, including prevalence rates and how those have been impacted by the COVID-19 global pandemic, go over barriers that caregivers might have to self-disclosing, which many of you, I'm sure, can talk about even more clearly than I can, but we'll talk about what the research has identified. Talk about the benefits of screening substance use concerns, and then actually what assessment approaches are out there. The advantages of using a validated screener, and at the end, talk briefly about one particular screener we're excited about, and we're hopeful you'll consider for your round of PDSAs focused on PCAP, which is called the UNCOPE. We'll go over that. All right, and I want to acknowledge we're starting off this morning with some heavy statistics, especially those related to our states, but I think they bear discussing and witnessing. So first, just talking about prevalence rates of substance use. A pretty recent report from the CDC found that about 20% of women in their first trimester of pregnancy report current alcohol use, and even 11% actually engage in what's defined as binge drinking, so meaning those levels for drinking enough to be classified as a binge. Beyond that first trimester, we see that 1.4% of women in their second and third are also drinking alcohol. And overall, about 40% of pregnant women who drink alcohol also use other substances. The most common of those are tobacco and marijuana, often because they're perceived as safe by these people who are using it because these substances are legal. And then to bring in just a thought about the consequence of this many substance use occurring in pregnancy. In Oklahoma alone, we see that an infant is born with symptoms of withdrawal from a substance every 25 minutes. So scoping in on our state here for a moment, the prevalence of substance use has continued to rise in the past decade over estimates that we have. And about 8 to 10% of adults in that young adulthood range, 18 to 25 years of age in Oklahoma, use illicit substances. Oklahoma is also in the top 10 states for heroin use and pain reliever misuse in that 18 to 25 year age range. And Oklahoma is in the top 10 states for methamphetamine use across all age groups that were assessed by SAMHSA. Put another way, just again to emphasize the prevalence that we experience here at home, Oklahoma is ranked second for substance use disorders among states. And according to the Oklahoma State Department of Health, 12 Oklahomans die every week from an unintentional overdose. Spend a moment talking about marijuana use in our state, and this is actually a recently published article by Dr. Deshay and her colleagues. And in this study, they investigated the effects of the legalization of medical marijuana in Oklahoma. So how they did this is they analyzed tests of blood, urine, and meconium of newborns at Children's Hospital here and also Comanche County Memorial Hospital, so 2 locations. And they compared these tests 19 months before and 19 months after that legalization of medical marijuana. And what they found was actually a significant increase in positive tests for the active ingredient or substance in marijuana, THC, in newborns. They also found positive test results for amphetamines, barbiturates, benzodiazepines, cocaine, alcohol, and opiates. So across the board, Lisa, am I correct to assume that was an increase in positive tests for all of these substances?
No, there wasn't an increase, but
Okay.
it was present in all of them.
Gotcha. Thank you for clarifying. Dr. Deshay, anything else you would add about this study before we move on?
No, you're on it.
Great, thank you. So this is one look at how law had affected substance use, we also want to talk about how COVID affected substance use. And there was a very recent paper that came out that was focusing in on mothers with current or recent active substance use while they were pregnant. And this study also compared a pre-pandemic cohort, so a group of people who had used substances during pregnancy prior to COVID, with a group who had used it during what qualified as that pandemic timeframe, so from January of 2020 through April 2021. And what they found was that fentanyl use increased, tobacco incidence doubled, the incidence of preterm birth increased pretty dramatically from 48 to 58%. And in another study looking at just over 7,000 pregnant people in Canada during the pandemic, they found that there was 6.7% use of alcohol, 4.3% use of cannabis or marijuana, 4.9% tobacco, and 2.6% multiple substances. So overall, we did see that during the pandemic, we saw spikes in substance use during pregnancy. I'll pause there, again, acknowledging these are some heavy statistics. Any thoughts, questions, responses before we talk about barriers to disclosing?
Hi, Dr. Fleming. This is Kathy in Tulsa. I just had a couple of comments. It's always frustrating to me when you hear about data and you look at it that we never really parse out first-time moms, which is our whole population. I don't know why that is. We've been around since, the 70s in the model as far as Dr. Olds, but that's just something that really I always highlight. And then Dr. Deshay, I had a question for you with the study that you did with Comanche and Oklahoma City. I'm wondering if St. Francis would have been an option with the Children's Hospital or just St. Francis in general, since it's such a large medical facility for some of the data, just on this side of the state.
We had checked with 5 different hospitals around the state to try to get partners on this study. And we tried to get St. Francis and we couldn't get their involvement. We were supposed to have St. Anthony, but then we ran into problems with the data. So of not being able to access everything we need to make valid comparisons. So that's how we ended up with just
well, thank you for trying.
Thank you. Well, and I appreciate you saying that about the first-time mothers, because half of my job is the MIECHV side of my job. The other half is in neonatology. So that's something that I can keep an eye on, and I might be able to inject in a study in the future.
Thank you.
Thank you for those comments. And I should have said at the top of this, I'm getting over some sort of virus. I'm okay, but still holding on to the vestiges of a cough. So forgive me if my voice sounds a little off or if I take a moment to cough. Okay. So in recognizing that there has been increases in substance use, and it's a very real concern and struggle for the families we serve in our state, we wanted to take a moment to talk about the barriers that caregivers might experience to disclosing their experience with substance use. And this is not an exhaustive list. This is what we found in the literature. You all might have additional thoughts about it, but to just highlight what just some of those barriers are, a very large one is that women fear losing custody of their children and facing criminal charges. Others report they might hold disclosing because they feel they have their substance use under control. A very recent meta-analysis, which is a type of statistical approach that takes lots of studies and looks at the effects over time together, found that people report a lack of motivation to quit using substances as a reason to not disclose. That the habit of using that substance is a way that they're coping. It's a coping strategy they don't want to give up. That they see benefits to marijuana use, such as reducing nausea during pregnancy, or that there's a fear of what happens if you cease using that substance, such as with smoking cessation. There's a fear of gaining weight. There might also just be some emotional barriers to reporting, such as experiencing shame and guilt around that substance use, or fear of letting down people that person trusts. having a lack of knowledge of the risks of substances, so perhaps not viewing it as a danger and therefore not feeling the need to disclose it. Belief that using substances in small quantities is safe or okay, or even that their preferred substance is not harmful in some way. Or that they feel like they're handling it because they're substituting substances that might be seen as more serious, like methamphetamine, for a substance that is perceived to be less dangerous, like alcohol. Some others that we uncovered in this literature search was that folks might be receiving conflicting advice from their obstetrician and their primary care physician, such that their OB might understand the morning sickness and the marijuana use someone might engage in to relieve that. There's also the fear of feeling judged and stigmatized for substance use, having lack of encouragement, or feeling that healthcare professionals aren't sensitive about substance use. A fear that actually those providers could come across as authoritarian or coercive as a consequence of revealing that substance use, making it harder to work with them. The belief that there's a bias against those seeking treatment. Again, that fear of separation from children, not just from removal, but being separated during the course of treatment. Not having social support from family and friends to support going through the process of disclosure. The fear of protecting other substance use users in the home. And perhaps that individual is just prioritizing what they perceive as more immediate needs, understandably, such as securing safe shelter or food, and deprioritizing this concern of their substance use. So in recognition that, yes, substance use is a problem in our state, and yes, there are many barriers, very understandably, to disclosing, we want to talk about the benefits of screening for substance use concerns. Some of them are that regular screening can allow early detection and treatment. A huge one is that you all are uniquely positioned as home visitors to have a trusting relationship with these clients and not have some of the barriers that a healthcare provider might have in another setting. And it might be easier to disclose to somebody who you trust. Even if the screen is negative, it presents an opportunity to discuss health promotion and continue kind of supporting prevention of substance use problems developing. And of course, it can protect folks who are pregnant and also the effects experienced by young children when their caregiver is engaged in substance use. So briefly about screening tools, we wanted to delineate that while it is important in the context of an intake to ask a variety of questions to understand the family and their needs, that asking about substance in the context of a semi-structured intake is not necessarily the same as utilizing a validated screener. There are a few key differences between these approaches that we want to highlight. One is the potential that how questions are asked can really affect how people answer, and you won't know that if the questions are untested. As one example, questions that can come earlier in a sequence of questions can affect how one might respond to those questions coming later in that sequence. So here's an example. Do you care about children's health? Most people will say yes. Do you want access to services that benefit children's health? People are going to say yes. Do you use illicit drugs or alcohol? And so these previous two questions might de-incentivize being honest in that third one. Intake questions can also lack comprehensiveness. So depending on how they are worded, if they've not been tested to know that they reliably detect substance use, you could be missing something that would have uncovered concerns of substances. And it somewhat lacks flexibility on timing of administration. When you do an intake, you do it, of course, at the beginning, whereas if you have a separate screening tool, you could wait to administer that till you've established a good relationship with that consumer. This graph is another powerful example of how the way you ask a question matters. So this was a study done quite a long time ago, but it's a famous example of methodology where they looked at discrepancies in the order and style. 2 questions were asked to screen alcohol use. And what they found, so down here is the age range of folks that they were questioning. And then on the y-axis is people who endorsed alcohol use. And these various lines are showing you the year. So this was a study over time. And in the year 85, they happened to ask these 2 questions in a different order and style. And they found a substantial observable change in the reported levels of heavy alcohol use. And we wanted to show you this because this really demonstrates that something as simple as altering the order of presentation or the style of presentation can lead to very substantial differences in how folks respond to questions. Not only was this such a stark change that they don't believe that in 85 people happen to just be using less, but we see in the years preceding and after, when the question order was the same, they were similar to one another. So establishing that we do think that screeners can be helpful, and we want to also highlight some of the benefits of what a screening tool can do. A big one is that they are tested in populations like the ones you serve. So they've been tested to show that they're valid for families that we serve. They're also found to be reliable. That's something we look at for a screener to be considered evidence-based. And what we mean by reliable is you get the same or similar response on 2 different administration times or occasions close in time. We want a test to be reliable because the advantage of that is, then that a change in those scores is probably due to a change in what you're measuring, here substance use, rather than something else, like how you presented the question. We also, another aspect of an evidence-based screener is that it's validated. And what we mean by that is that it's been tested to show it measures what it is supposed to measure, and that it can do so sufficiently. And if it does, that means that it can be even productive of other behavior related to it. So again, here, substance use. So that foundation, we wanted to introduce a particular screener that's called the UNCOPE. What's great about the UNCOPE is it meets all those criteria and that it's reliable and valid. And it's only 6 items. So it's a 6-item measure for substance use screening. There are a wide variety of studies that have confirmed its validity with a wide variety of community populations like the ones we serve here. They've been able to show it's able to accurately identify people who need help versus people who might not. That it's been found to be reliable across administrations. It's free, which is great. It's also available and validated in English and in Spanish. Those 6 items are presented in a simple yes/no format, so it's also very quick to administer. And we had the opportunity to meet with another state that has been awarded the same grant that we're working on, this innovation grant in Nebraska. And they are wonderful, and they've used for their home visiting models the UNCOPE for many, many years. And they have an administration guide that they very happily shared with us. So that would also reduce training time. It goes over all the information about how to administer. Here are the items, just so you all can see it. It asks about the past year. So that's the frame of reference. And the cutoff for when you would refer someone to services is if they endorse 2 or more of these items has been found to reliably identify folks who might need help. So again, you go yes, no through these 6. If there's 2 or more, good sign that they might need a referral. There is also one follow-up question. It's just to assess what substance is being used. We recognize there's not an other, which can be limiting, and that might be an additional question you can ask about if it seems indicated in the context of your relationship with that person. But it does get kind of at the major hitters that we see with substance use. All right, thank you for bearing with us as we went through this. So just to summarize what we've talked about this morning is that vulnerable populations become more vulnerable when substance use is present, that the prevalence in Oklahoma continues to increase and represents a very real struggle for the families we serve, that families might not know where to turn, or they may need education on why substance use can be harmful for them or their kiddos, that there are a lot of barriers to disclosing and thus obtaining the help they could get through disclosing, to emphasize that home visitors are in a unique position to be able to offer acceptance and help for those using substances and to administer those screeners. And that the UNCOPE, which we hope that, again, you'll consider using in your PDSAs, is a simple, short, valid measure that can be used to screen for substance use. If you are interested in any of these articles, please let us know. I'm happy to share them with you. You can contact Dr. Deshay or myself.
Thank you, Tabitha. Comments, questions? Okay, let's go on to your PDSA stories. Here are the programs represented today. CAP Tulsa, LCDA, North Care, Parent Promise, and the Tulsa Children's First. So let's get started. CAP Tulsa, would you like to do your presentation on your PDSA story?
Yes, we're trying to see if, are you gonna pull it up for us? Are we gonna pull it up? Okay.
I can pull it up if you want me to.
I can do it.
Okay.
She's getting it. So
Okay.
we'll be ready in a minute.
And then after that, we'll go to LCDA, and then we'll take a break, and then we'll come back for the next three programs to present.
At rooms 1 through 4, 17 and 18. Will you please send me an email every child enrolled and their diaper size? I need their name and their diaper size emailed to me immediately.
Okay, is this
Thank
the
you.
best I can do? Okay. We just the screenshot. I need to screenshot. What is it? We were there.
I should have dropped a note in the chat telling y'all, I'm going to put you up first.
Yeah. Okay, so can we share on the left? Share screen. Yeah. And it's got the second option. Yeah. There we go. Okay.
Okay, make that room 17, 18.
Can you see my screen?
Children's name.
Yes.
Their diaper
Okay,
size.
can you hear us clearly?
Thank you.
Yeah, we can hear you.
Okay, so we are presenting our PDSA story. Our smart aim was thinking on 80% of our families that had legal challenges will be referred to legal aid through Oneida Us. And the second one was that 25 of those families will be enrolled in LASSO. So this is our CHAN 30 diagram. So the process will be that the idea was, of course, the goal is to make the referrals through Oneida Us portal. So we were doing, the parent educators will present the brochure, the LASSO brochure to the families and discuss with them the eligibility. And then for those eligible families, they will be referring to LASSO, the ones that, of course, are eligible, and they will sign, ask parents to sign a release. The parent educators will complete a referral tracking, and the PDSA, the developmental PDSA for this year. And once they have that done, we, Caroline or me, will be doing the referral using the Unite Us portal. What we were expecting to have a disruptor. Well, we have families that may not be eligible, that they were not service available for those families, the families that refused to be enrolled in LASO, or families that were unable to contact from LASO. So at the beginning, what we prepared was having the parent educators. Well, we received the brochures in LASO. We have actually in English and in Spanish, and we have parent educators to show those to the families. We didn't use the screening. We used the brochure to screen the family. So the parent educator discussed with the family. They went through the brochure and see if the family have any legal needs. We have a training with all the parent educators attended to a training with Kayla Woodbury from LASO that help us to navigate Unite Us. I'm sorry, parent educators have the training with LASO, and Caroline and I have the training with Kayla Woodbury from Unite Us to learn to navigate Unite Us. And I have that I said this before, so we have the parent educator presenting the brochure, then discussing with the family, seeing the eligibility, obtaining the written consent. At the beginning, we didn't use written consent. We have a verbal consent, but then later we learned that having the written consent will be better for our process, and we're going to talk about that later. The PEs will complete both the referral tracking and the child developmental PDSA for this year. And upload the consent there in the PDSA. We have upload the button so they could have that written consent there. I will be, or Caroline, pull that information from the PDSA, run a report, see how many families were enrolled or, referred to LASO to go and process them, those referrals from in Unite Us. Unite Us have a process that when you complete a referral in their system, you will receive notifications for that family when the referral was accepted and if it's and any follow-up. The parent educators will follow up after with the family to see if they have, received any call from Unite Us, if they have been have any follow-up from Unite Us. Our outcome measure is a proportion of families that have the legal need that they were referred to LASO, and then the families that were enrolled, once they were referred to LASO, they were enrolled in LASO. The process measure, will be the proportion of families that are active that receive this LASO brochure. And for us, all the families in the program that were active, they receive a LASO brochure. The disruptors, we use for the disruptor measures, the options in Unite Us when you couldn't get a referral completed in Unite Us. So would be client declined the referral, the family refused to be enrolled in LASO, the family is ineligible, and no LASO services available, LASO was unable to contact, or others. So those are the options when you couldn't process a referral in Unite Us. Those are the options there, so we use the same ones. So we have 4 referrals to LASO. We have 1 accepted, 1 declined, and 2 rejected. The reasons for the rejected and the decliner are almost the same, but I don't know why the Unite Us just decided to classify as rejected or declined it. So we have two families that they just declined the services because they didn't need the services anymore. They already have found legal aid, or the situation or challenge that they had, it was resolved. And we have one family that actually rejected the referral because they say that they didn't disclose the information to anybody, and they were like really concerned about their information going out. So we have to reach the family and explain that it was with their parent educator. It was a confusion there, but that was the only one that really like rejected. They were not interested on getting help from LASO. We do have a family that accepted, and it's an open case in Unite Us. The experience with the referrals, well, for us was a little challenging to identify the referrals in the referral tracking, the LASO referrals versus any other legal service or any other service, and that's just because that's ETO. And we have this issue with this family that they saw that they didn't have a consent, and they didn't know why their information was given out to LASO. And starting on that point is when we decided to go to the written consent instead of the verbal consent. So we have the form that that show that the family accepted the services. We think that this process has increased our awareness to LASO, and parent educators are more familiar now with the information and when doing the referral. And we also have been receiving other referrals from other agencies using the Unite Us. This was Unite Us wasn't like new for us, so it's I think it's a great tool for us to that will benefit our clients. And that's all. If you have any questions for us.
Did you have anyone that had, I don't know, immigration issues, or they were going through a divorce and maybe didn't have papers? Did they take those referrals, or you didn't have anybody?
I have just one family that have have like trouble with, I can't say, but trouble like with her partner, and she needed legal help to that. And once you do the referral to Unite Us, you don't know anything that happened there after. So you can't go and see what is going on and following up. You just get the information that is if the case is open, and the caseworker from LASO follow up, but you don't know anything about the case unless the parent educator, of course, asks the family.
I see. I have just a comment, maybe question for Dr. Barr. I can see how maybe for the goals that we have of increase, the families are sent to LASO, even MIECHV. I don't know how much of that, but for Sooner Start, in LASO, what I was hearing you presenting is that you are letting people know if you have any legal issues and bringing the brochure. So there is more chances to increase that, because we have never really presented something like that to families. But for example, for the Sooner Start, unless the child has a disability or a possible delay, that's when you're going to do referrals, because we do 100% of our clients would refer them to the services. So increasing or having, if the average was, I don't remember if you said 5 or 4, and now it's 6. I mean, I will be referring the same amount of families as we find them that they have a possible delay. So there's no way that I can increase that unless I have families that have a possible delay.
Yeah, no, it's a good point. We have thought a couple of times that the numbers may be a little bit lower simply due to documentation, and to be more specific, there instances where the ASQ seemed to indicate there was a developmental concern, but a referral wasn't made. Diving into some of those issues, I think with your program in particular, we found that, well, the referral wasn't made because the family had already been utilizing early intervention previously.
All right.
And so our hope is that for those referrals that where a referral wasn't made, we have documentation now of the reason why. And we might see a little bit of a bump there, but it's a good point. And yeah, we're, for that objective number 2, anticipating higher increases for LASSO and for PCAF than we are for Sooner Start.
Okay.
On the Sooner Start front, we're also hopeful that we can reduce some of that time lag between the date of the referral and the utilization of service, and just having the documentation, the greater detail of documentation coming back from Sooner Start to your programs, we think is going to be a strong statement of success of the project. So
yeah,
that
absolutely.
objective 3. Sorry.
Absolutely. I think that's, to me, when I was thinking and the objective that you were presenting, it was more like, what is the lapse once you send them now to Sooner Start? How long does it take for them to be served? Not necessarily increase all the referrals to Sooner Start, but more, what's the process? Did you reduce the time frame for that referral and the time that they get services? To me, that will be maybe, but if you're considering already that, that's perfect. I just had a, question. Yeah.
That's a good question. I should have called it out myself earlier. And, when we write the final summary of findings here, there'll be narration to go with each of these data points and programs. So that's one that we'll definitely document in detail, that you had an established relationship with Sooner Start. You have these procedures in place for when to make referrals. So we didn't anticipate there being a big jump there.
And I'd also like to add to this presentation that I heard you say that you don't know what happens after the referral's been made, but that's going to change some, because when in just a couple of weeks, we hope sooner than a couple of weeks, we hope by the 18th, then you will be able to see the custom forms for in Unitas, where we're collecting the information about what we called the program engagement mile markers. And I think everybody here reviewed those mile markers. And that's where once that custom form is in place, then you'll be able to see, oh, okay, they did receive the referral. They've tried one time to contact and they were not able to contact for this reason, or they've made 2 attempts to contact, and they may reach out to you to confirm contact information, or you may see that an appointment has been made. It just depends on when they get their paperwork signed, allowing them to put such information into the Unitas program. So those custom forms that we've talked about will be collecting the engagement mile marker information, and you should be able to tell more and get that more two-way communication going that's part of our goal with Unitas. Thank you, PCAP. Now I'd like to go to LCDA.
Okay.
Are you ready?
Can you see it?
Yes.
Ours is going to be a little bit different just because we really haven't started. Well, we have referred families, but just the regular way, just because the contract or I don't know, the procedures for them to start doing this are not in place yet. So basically, our change theory is we're going to screen the children under 3. Oops, move just a second. Under 3, and we're gonna the ASQs, ASQ3, ASQSC2, and whatever is a possible delay will be referring to Sooner Start. The PEs and the family support workers, they're gonna, of course, select the appropriate ASQ for this. Then they're gonna identify those children, already said that, with the delays, and we're gonna utilize Unite Us, and of course we're still going to have to enter into ETO, and what you were saying, that we're hoping that with doing it through Unite Us will be a faster process to get them enrolled into Sooner Start. Possible the family, maybe, if if we can't do it, maybe they refuse the child screening, then maybe they're already receiving services, and that's why they're not being sent again to Sooner Start. Or if they refuse, the referral will be some of our I forgot the word. Okay, when I go to the presentation, I inform you. So the SMART aim is that through the use of the NIDAS care coordination portal, we're going to ensure that 100% of the children under 3 of age with identified developmental concern, they will complete the Sooner Start referral, and we're hoping that 75% of the children will complete an intake, and if eligible, they will have an interview and be able to get services. The only thing that we have been doing is that we, the way we'll be doing it, and even now we're doing that, but we do, of course, the ASQs, we utilize these existing talking points that we have to discuss to the families, which has helped us a little bit to unify the way we present the families, why sometimes, we see delays in children, how you going to, why it's important to have a following appointment with an assessment, and now we're going to present that this is the way we're going to be doing the referrals. We just have the training, but only the supervisors. We have discussed this with the staff, and we have been participating in the rounding calls. As I mentioned, we're gonna do it through United Us and ETO, and we do keep a spreadsheet on a separate note, just because it was for us a little difficult to navigate ETO, and we do have, who has a developmental delay in any actions that have been taken, or if they're waiting for services, or they refuse services, or whatever the action was, and it's updated on a monthly basis. And honestly, we kind of rely more on this spreadsheet that we keep. So the providers, they're going to be following the schedule that we have for the ASQs, and they can supplemental those if they maybe see, of the mom is mentioning that they see something or they have a concern. So we can do extra of those. So if the children already are showing possible delay, we use the talking point sheet, and we just kind of talk about the areas of development that they might have delays that is not really related to the child's intelligence, and how children develop in a different way, and just having this support, or if they get therapy early enough that they can just overcome this, that there are different type of delays, and what kind of assessments are out there, the kind of specialists that are out there, and that kind of thing. So what we're going to be doing is that we will be entering, the Ps will be entering the referral in ETO, and the supervisor will be entering the referral in the Unite Us. And basically the supervisors and the director will be monitoring, not us, not necessarily the PEs. So what is going to happen? The way we do it right now, what you were describing earlier, is going to be a lot easier just to know if they have been contacted, because in the past the PEs will ask them in the next visit, have you received a call from the agency? What kind of, if they contacted you, if they're going to have an assessment, that kind of thing. But now is going to be, we're going to rely on the information that Unite Us gives us. And hoping that will accelerate the connection with Sooner Start. So our outcome measures percentage of children under 3 years of age with the developmental delay, who will either screen ineligible of Sooner Start intake. That the denominator will be number of children under 3 who were referred to Sooner Start, and numerator number of those children who were ineligible for services. And for the other one, the screen eligible and completed a Sooner Start family interview. So our denominator will be the number of children who were referred to Sooner Start and were determined to be eligible for services. The numerator will be the number who completed then that family interview. So for the process measures, it's going to be the percentage of family who successfully connect with Sooner Start provider and schedule an intake assessment. So again, the number of families that we refer and who are the families that have been assessed. The disruptor, that's the word I was just the disruptors that we might see will be just the number of families with a child identified with development concerns and who refuse the referral to Sooner Start, which is going to have one. And basically that's it. We don't have any data or anything because we have not been able to, you said that maybe the 18th?
Yeah, that's when we're hoping that everything will be ready to go with the custom forms and everything, so that you can be getting information back, and Sooner Start will be on Unite Us and so forth. Yeah, so that's the plan.
Yeah. So we're just still waiting, but we have done several referrals to Sooner Start, and we're just doing the procedure that we used to do. So we're hoping that this changes once we start on the 18th. Hopefully, the things will, we'll have data or information to share.
Thank you. Questions, comments for Patty?
I would like to say, Patty, thank you so much for speaking up and saying that you're doing a separate, your own tracking sheet, because I know with some of the new systems and like for us, we'll be looking at ETO and Unite Us also on how to track these referrals we're making. But since we're in the process of learning, having an additional log that we're keeping, I could see being very beneficial. So thank you for sharing that, Patty.
Absolutely. Yeah. I mean, basically, whenever we need to do our reports and everything, that's where we go. I don't go because, it's not that many kids, fortunately, that, that you're following. And then you can have just the steps and action waiting for services already. So you just keep adding, and it has been a great way just to have it instead of being looking at ETO. And so as you do it, you just enter that information. It'll be great.
And you might also, when this afternoon, when we have the training with Kayla, you might ask about what kinds of reports that you can create eventually in Unite Us that would give you that same information. She may have some ideas.
Yeah, Lisa beat me to it, and we'd hate for you to have to duplicate that entry long term. So this is a unique opportunity, we think, to customize these forms and Unite Us, and especially given the two-way interactions that it enables. We're hopeful that we don't have to have a third and fourth logging system moving down the road. And this is sort of a chance to pilot test that.
Other comments, questions? Okay. Let's take a break and come back at 10:40 and we'll pick up with North Care's presentation. Thank you. Hi, everybody. Why don't we go ahead and get started? Dwan, are you ready to get started?
Yes, I am.
I just want to say that Dwan's colleague is usually the one who does these presentations, and she unexpectedly had to be out of the office. And so Dwan is less familiar with the presentation. So if I jump in, I'm not being rude. I'm just trying to help her out. So, but I have total confidence in you, Dwan.
Well, thank you, Lisa. I honestly would like to just say, could I do like Patty's presentation and do a ditto? Because I feel like we're going to be repeating. But we will get started. So our SMART aim is 80% of children who have identified the need for a referral are connected to Sooner Start. And that 90% of the family interviews that Sooner Start has with our consumers that we have a home visitor present for, that initial interview that Sooner Start does. So we would do that by, first of all, just increasing the staff's knowledge of Sooner Start altogether, and increase the connection of families to Sooner Start. We have a fairly new team of providers, and so there's been some staff changes, and so this is a great time for this to be happening, because then we can really train everyone on Sooner Start and what they offer. Also, we would complete the ASQ to determine the need for a referral for the family. And of course, one of those disruptors is the family could always refer that referral. That is something that does happen sometimes. We're looking at the percent of identified families referred to Sooner Start that meet the qualifications. Another disruptor could be family does not qualify for the Sooner Start services. Obviously, we make the referral, they do their assessment, but they don't meet those Sooner Start requirements. And then percentage of Sooner Start family interviews with the home visitor present. And then another disruptor is families may miss the scheduled appointment. And so, and at the end of the day, we're going to use Unite Us for those Sooner Start referrals and to help us track the processes being made. So our plan, we're going to use our ASQ as our main tool, which is great because it's an assessment that all of us already use. The actions that have been taken so far, I know Jada and I met with Unite Us several weeks back, but then on August 4th, it said supervisor, but really it was the whole team was able to be trained by Unite Us on August 4th. We still need to schedule a Sooner Start training. To my understanding, there hasn't been a date set for that. And then just regular discussions during staff meetings and supervisions with the providers. Where will your program record the data? We're going to use the ETO referral tracking touchpoint and Unite Us platform, but I think I'm going to borrow Patty's idea and us just at least keeping a list of the referrals we've made so we know where to follow up to make sure as we're transitioning to these new systems that everything's in alignment and going smoothly. So our due step, what is going to happen between the steps will follow the ASQ schedule for screening. So even if a family doesn't maybe initially qualify in their first ASQ, we have these routine ASQs that are scheduled that we'll continue to do additional screeners. So ASQ, autism, or whatever might be of concern for the family as requested by the family. Also getting them connected to other services too, if we feel like there's additional screeners that need to occur. Actions we'll be taking, talk to the family about how positive parenting includes knowing where the child is developmentally. So really helping the families know where their child is on their developmental process and how positive parenting factors into it. Talk to the family about the results of the ASQs and what they mean and whether referral is needed. And sometimes activities can just, if it's just a monitor, like let's continue to monitor this at the time, the workers providing those activities for the family to do with the children to hopefully keep them on track. When a referral is recommended, obtain the release of information for making the referral, and then tell the family what to expect from Sooner Starts, and being just as transparent as possible with our families. And then explain that the home visitor will attend the first meeting. We're hoping that this helps reduce anxiety for families. There's a warm handoff. And so the family needs to keep in communication so we can do that. Let us know if Sooner Start reaches out. I believe on Unite Us, we'll be able to track that also, which will be wonderful, but just to have that communication going. Also, what needs to be created, we just need Unite Us, it sounds like, getting that process set up with Sooner Start. Who will monitor it? So home visitors will enter the data into ETO and notify their supervisors, and the supervisor will put the referral into Unite Us for them. How and when will referrals and screenings be done? During home visits on the ASQ schedule, Unite Us referrals will be entered after the home visit. Tracking measures, developing a new ETO item for child development, PDSA, new touch point to indicate the home visitor was present for the first Sooner Start meeting. So we'll need a way to be able to track that in ETO. What happens when the family refuses a referral, which can be a disruptor? Encourage the family to focus on provided activities from Safe Care related to the child's specific milestones being pursued. Document the refusal. We'll check in again on the next screening and talk again to the family about Sooner Start if the developmental concern is still present. I would also add to this, our team's trained in motivational interviewing, so that's when our motivational interviewing skills would come into play also. After referral, what happens? Look to Unite Us for documented attempts to contact. If there are any barriers to contact, and follow up with Sooner Start and family as needed, and check with family about their Sooner Start experience. So with Unite Us, I think it's kind of a neat system. I'm excited we're doing this because before you make those referrals, you don't really know where they're standing. So having Unite Us as a way to look into that. So our outcomes measure would be the percentage of family, and we don't have any data either yet, just because we haven't started this officially. But what we'll be looking at is the percentage of family interviews with Sooner Start that have the home visitor present. So we'll be looking at the number of families with Sooner Start interviews and the number of those that have the home visitor present. Also the percentage of children with identified need and schedule for the need schedule family interview. So number of families with children with an identified developmental concern and the number of families who schedule that interview with Sooner Start. Our process measure will be the percentage of families needing a referral based on their ASQ who are referred to Sooner Start. So we're looking at the number of families needing a referral in comparison to the number of families who are referred. And then just some of our disruptor measures. Family refuses ASQ assessment or referral to Sooner Start. I honestly have not known of a family refusing an ASQ, especially for our identified child. However, and I didn't make this presentation, but one thing I would like to add to this is sometimes, especially those initial ASQs, as we're still building rapport with families, like was talked about with the other screeners, families, we do try to have the child demonstrate the skills for us, so we have the most accurate ASQ, but sometimes that just the child's not cooperating, or we're having to rely on parents' reports. And so sometimes those ASQs may not be fully accurate at the time of assessment. So I could see that being a disruptor also. Family cancels or misses scheduled sooner start appointment. Child does not qualify for services with sooner start. Sooner start doesn't connect with the family, and family doesn't connect with sooner start to schedule the appointment. And then provider can't make it to the family interview with sooner start, the initial, just because of scheduling conflicts or circumstances. And I believe, yes, that is it for us. Oh, Lisa, you're muted.
Thank you. Thank you, Dwan. You did that like a pro. Questions
Okay.
or comments for Dwan?
Hey, this is Dava. I was just wondering, I know in our process in Unitas, there is a consent, no release in Unitas. Do you guys use that, or how does that look for you?
So yes, there is that piece that the family would have to sign, but we also have a referral, a release of information on our agency side to say that we can put that information in there.
Gotcha. Thank you, Dawn.
Yeah.
Other comments, questions? Okay, let's go to parent promise. Alicia, are you going to be presenting today?
Yes, I'll be presenting.
Okay.
Let me see. Pull it up. Oh, can you see it?
I see the experience so far slide.
Okay. Can you see it now? Is that?
No, I see experience so far.
Huh. Okay. Oh, I'm not sure why it's not doing it. Let me see.
I could share the slides if you want me to.
Hold on. Let me. Yeah, you might have to, because I don't know what's going on.
Okay. If I can, let me see. Oh, I don't have the pretty background. I don't have the latest version. I think what you start, I think what you started to show will be okay. You don't have to do it as a slideshow. You can just do it there on your screen. Yeah. If you show your screen, you can click through them. You don't have to do it in slideshow mode. I think we'll be able to see what we need.
Because I don't think it's in slideshow mode. I think it's.
Just click through there. That'll be fine. If you click on the slides on the left-hand side.
Can you guys see it? Is it?
Just, you don't have to do slideshow mode. You can just do it from this screen.
From this screen, okay.
Yeah, and then just click on the left where it says slide 2. You can go to your next slide there.
Okay, I gotcha. Okay, so this is, we're Parent Promise, of course. And this is our PDSA story. So our change diagram, so our SMART aim is through the Unitas, we would ensure that 75% of the children under 3 years old with a developmental concern would complete a sooner start intake or interview. And so from that, the PE would administer the ASQ3 or the ASQ SEs. And then if there is a concern, the PE would make the referral through the Unitas. And then some of the disruptors were either families didn't qualify, they were ineligible, they just didn't, need a referral, or families refusing referrals. And then from there, of course, the PEs would follow up through the Unitas within about a week or so. So the Ps would also follow up with families at the next scheduled home visit. So typically that's within every 2 weeks. So within a couple of weeks, they would follow up with the families, and then families and children receiving services in a timely manner. So then our plan, what tools or resources have you prepared? So of course we use the ASQ3 and the SE, which are already available. We've been using them for some time now. And the actions taken will, with weekly supervision meetings, we would ask about the current ASQs, the referrals being made to Sooner Start, and whether families agreed or to the referrals or whether they refused. And then where we would record data required for the outcome process and disruptor message would be an ETO and the referral tracking touch point. And then our steps, the PE, of course, would administer the ASQ3 or SE at the intervals required by the health department. So there is a baseline done at about 4 weeks after enrollment. And then we would have a conversation with the family about the ASQ results and what the Sooner Start experience would look like, kind of what their process would be as far as contacting the family and scheduling the interview and things like that, just to make the families a little bit more comfortable about the process, hoping that they would go ahead and accept the referral. Ps would make the referral through the Unite Us, and if there is a concern, and the referral, whether it be declined or accepted, would also be recorded in the ETO touch point. And then we will start the uploading of the ASQs to Sooner Start. And then Ps would follow up through the Unite Us within about a week. And then, of course, the supervisor would also check in with this before supervision meetings with the Ps about the referrals, and then the Ps would follow up with families at the next visits. Our outcome measures, so the percentage of children under 3 with a positive home visit administered ASQ3 or SE who completed a Sooner Start family referral. So we're looking at the number of families with children under 3 with a positive ASQ during the review period, and the number of families who complete a family interview with Sooner Start. And then our excuse me. And then our process measures is the percentage of families who successfully connected to Sooner Start provider and scheduled an intake assessment. Excuse me. And the number of families referred to Sooner Start in the Unite Us. And then the numbers, excuse me again, number of families who scheduled an intake assessment. Oh.
Talking can really dry out the throat.
I'm going to have Courtney is on, and she's going to go ahead and continue for the next couple of slides, just so I can get some water. I'm sorry.
No problem. Sounds good. Hi, Courtney.
Hello. Can you hear me?
Yep.
Okay. So, yes. So out of the families with a child screening positive for developmental concerns, the percentage refusing a referral to Sooner Start, the denominator was the number of families with children screening positive for developmental concerns. The numerator is the number of families refusing a Sooner Start referral from the PE. And then the percentage of referred families who screen ineligible at the Sooner Start intake is the number of families screened for Sooner Start services, and then the number of families whose Sooner Start intake resulted in a decision of ineligibility for services. And then our experience so far, most time spent waiting for Unite Us to allow Sooner Start referrals. Unite Us has been great for finding other resources. One of our PEs had previously worked for us and then came back to the job recently. So we've had conversations with her about the PDSA, and she has started learning about Unite Us as well. And I think is that the end? Yeah.
Okay, thank you, Courtney.
Yeah, sorry.
Questions, comments? Did you have more you wanted to say, Courtney?
Oh no, I just want to apologize. I kind of rush through stuff sometimes.
No, you did just fine. You did just fine. Any questions for Courtney? Okay, we've got one more presentation before we take a lunch break. Dava, are you going to be presenting for Tulsa Children First?
I am.
All right, I'm turning it over to you whenever you're ready.
Good morning. So let me try to share here. Okay. Are you seeing that okay?
It is there. We see it now.
All right. So our PDSA was on LASSO. So this is just information on the Children First program. Our client count from January for 2023 was 136 clients. We do have 3 MIECHV providers, 8 non-MIECHV, and 2 supervisors. 2 nurses are currently onboarding. So our key driver in Smart Aim, our key driver was referrals made based on assessment results that reflect social determinants of health addressed by referral partners. Our Smart Aim was 100% of all clients with legal concerns upon screening will be referred to legal aid services through the Unite Us application. We didn't do any training on the Unite Us application because we've been using it about 1.5 years. So they were very familiar with that process. Here our outcome measure with the percentage of active mothers screened for legal concerns at least once within the review period. Our process, the nurse contributed input during a team meeting. Proper screening tool and handout was developed, and the nurses used those resources to screen each family on their caseload. Nurses completed a LASSO referral for families in need of services in Unite Us using the MIECHV CQI tab.
Excuse me, did you create your own, didn't you come up with your own screening?
We did,
tool?
and I put that in here to
oh,
look
okay,
at.
good.
Yeah.
Thank you.
So our numbers, the number of families screened for legal concerns. Our disruptor was the percentage of mothers who refuse the assessment. So that would be the refusal of assessment over total screen. A percentage of mothers with an identified legal concern who refuse a LASSO referral. So that would be the number of referrals, refusals of the referral and total identified legal concerns. So our next one is our change theory diagram. Not a lot to say about that, really. We identified a screening tool, presented that. Our disruptors basically were refusal of the screening process or refusal of a referral to LASSO. Here, we introduced the CQI process during a staff meeting in February. After review of the LASSO screening tool and services available to the client, the nurses developed a screening tool for use with clients to determine legal needs and potential referrals to LASSO via Unite Us. The nurses had a meeting March 7th here at Legacy. They collaborated about the screening tool and implementation. We had a LASSO infographic that we introduced services to the family, and the team agreed upon a start date of April 7th to begin screening. Oh, I'm here. Okay. So this was the infographic that we used. Introductory script was used to introduce the client to available LASSO services. Family was assessed for eligibility using a 7-question screening tool developed by the nurses, and this infographic was used. So based on the answers to the screening tool, the nurse may inquire further regarding legal issues and needs asking questions such as, do you think you have a need for services based on questions we've discussed? If the client agreed to a LASO referral, the nurse made the referral in Unitas for services. They also put that in the referral tracking in ETO. The referral was followed up in the next visit with the client to determine any further questions or clarification needed regarding the referral. This is actually the screening tool. So we had employment here, income and consumer, housing, health barriers, family and personal, and let's see. So here, early in the CQI process, nurses commented that several clients encountered delay on their referral from LASO due to staffing issues. Sometimes referral follow-up from LASO required up to 3 months for a callback regarding legal issue, but this was quickly remedied with the activation of the referral tab, which allowed LASO to confirm the client was participating in the learning collaborative. Our bilingual nurse did not experience any issues with regards to client immigration status and the ability to receive services. Additional issues involving LASO referral, they dealt with child support, employment discrimination, eviction, and protective orders. In some cases, LASO was not formally able to accept a referral, but they were helpful in providing guidance and support in addressing some issues. Lessons learned. We learned in the process that some information in Unitas was not available due to a conflict of interest issues related to follow-up details and number of contacts. That data would have been helpful in the to have in place in the beginning to assess if we were meeting our goals. Nurses' attitudes and comfort level improved regarding LASO referrals, and the nurses are curious if current success with referral and timely response with LASO will continue after completion of this project. Nurses frequently referred issues such as domestic violence, paternity, to the Family Safety Center and DIVIS, knowing LASO services were embedded in these agencies. Landlord-tenant issues were often referred to Housing Solutions and Iron Gate Ministries, where LASO is also embedded. And that is it for us.
All right, thank you, Dava. I think you had several interesting comments there. Other home visiting agencies may be interested in your tool for screening for LASO services. So if you don't mind emailing that to me, we'll have it available. Comments or questions about Dava's presentation for Tulsa C1?
So how many clients did you refer and how many they accepted?
We haven't gotten data on that yet.
Oh, okay.
Yeah, and we're not done. We're still going to continue this PDSA through the fall. So other comments or questions for Dava?
David, can you say more about the data that you'd like to get in return? But I think you referenced a conflict of interest. Can you give us more detail there?
Yeah, some of it had to do, we even ran into one incident where LASO couldn't take our client because the partner of that client, the parent, co-parent with that client, was also seeking LASO services, so they couldn't take our client. And I guess they weren't allowed, we weren't allowed to see some of that stuff in Unitas because of that situation.
I would like to know exactly what the question you have, like how after this CQI are we going to be able to continue referring families to LASO, because you're going to see an increase and it's a great, collaboration, but once that's out, I mean, we have, I don't know, I mean, it's hard sometimes to get services from them, so I wonder if that would stop after we finish this project.
Yeah, the nurse, this is Kathy. The nurses in our meeting on Monday, when we were asking them for lessons learned and their feedback, that came directly from them. Will this continue, or when we shift back to another project, or when we move on to another project, will we have the same response level when we send referrals and Unitas to them. That was something the nurses asked. I also wonder, and I don't know if we're able to find this out, but I know from the experience of having Unitas, receiving referrals in Unitas from other agencies for Children First referrals, that if they sit for 3 or 4 days, I don't know the exact window. It's usually 3 days. They will start contacting the receiving referral person to say, hey, what's going on? Are you working on this? You know, I don't know the verbiage, but it's a contact from Unitas on behalf of that referral source to say, we sent a referral, we haven't received any feedback. So I'm curious if that was the case with Lasso, or were they able to turn around the referrals pretty quickly? Just a question I had.
I don't know if our Lasso representative liaison's with us this morning. Scanning the roster here. I'm guessing not, but she will be here this afternoon, so we might be able to get an answer to you before we finish up for the day.
And that's not a negative, Dr. Bard. It's just I'm curious because, for instance, we have full caseloads right now. So I got an email a couple weeks ago, and I just had to send an explanatory reply letting them know our caseloads are pretty full. And as clients exit off a caseload, the nurse takes on the next referral. So just a question. It's not a derogatory comment. I don't want that to be the case.
I didn't feel that. I perceived it quite the opposite. I thought it was a positive, but it's easy.
Oh, good.
Somebody sort of double checking the lag between the issuance of a referral and a response. Right. Well, I'm not going to tell you anything that you don't already know, but to the question of will this relationship in its current capacity still exist when the project is over? I think it depends, and it depends on the successes we experience over the next year. It also obviously would depend on the acquisition of additional funding to reserve time from staff, Lasso staff, for example, to devote to those requests. Nothing will prevent you from continuing to make referrals to Lasso after the project ends, but their capacity may decline if we can't secure additional funding to devote FTE specifically to home visiting.
Dr. Bard, you're correct that maybe when you were saying that pipe that you saw after the presentation, because even though we don't have, we're not doing the project right now with Lasso, we have situations where they were super crucial that someone, legal assistance to some of our clients. So I think they have referred maybe 4 from Safe Care. None of them have been able to get, services. Hoping once we have this specific CQI with Lasso, then maybe that would be better. But we have referred them even though it was not through United. So we did it like on the side. They took the cases, gave us some feedback and some things, but they did not really help the clients.
That was early days before I think we even had our contract in place with Lasso. So the money wasn't flowing yet. They didn't have FTE reserved. They do now. So I am hopeful that if we see another spike like that, you'll get a different response.
Maybe that's telling us how we'll be after the fact. If they don't have the money, that's exactly
No, that's
we'll
true.
go back to.
Good observation. Yeah, I agree. We're here to be advocates for you all. And so this is one issue that we've sort of earmarked, and we're hopeful then the final report that we put together, we can emphasize this and leverage that for additional funding.
Thank you.
Thank you, Dava. Other questions or comments for Dava? David, is there anything you'd like to say before we head to lunch?
No, I think we're good. Oh, David, sorry.
David.
I was confused by
Sorry, Dr. Bard.
Well, just that, this is exciting that we've made it to this point. I know it feels like it's been a long journey already, but we're roughly halfway through this project. And this has kind of been a white whale for not only home visiting, but a lot of social service community agencies to have a system like this in place that can facilitate bi-directional communication. So I'm excited. I hope you are too. And as you'll learn as we come back after the lunch break, we truly are on the precipice here of making this available to all of you. And excited to see where these PDSAs lead us in the next 4 to 6 months.
All right, thank you. We will return at 12:30, so you're getting a little more than an hour for lunch. And that's when Kayla Woodbury will be here to talk to us about custom forms. I'm just going to leave my connection on and have this screen on there as a reminder. But if you want to log off and log back in, that's just fine. And we will see you at 12:30. Thank you, everyone.
So thank you. We would like you to start thinking about the next PDSA. I know that sounds crazy since many of you haven't really started the one that you've been working on for several months, but we're on a bit of a disjointed timeline for the project because of all the contractual hurdles that we had to cross. And frankly, we kind of liked the pace at which you were afforded to develop the current PDSA that's going to start in about a week. We thought that there were some advantages to laying out tentative plans and even due steps now for the future PDSA that we can be talking about simultaneous to your work on the current PDSAs over the coming months to sort of enhance and hone in on the targets and the goals of your future projects, where you choose one of the other referral network partners and design another Unitas related PDSA. So we're going to go into breakout rooms here in just a minute with just your programs. The analysts that are assigned to your group will be circulating and sort of be flies on the wall, but also probably pose a few questions here and there, particularly on the measurement side of what types of goals or outcomes and disruptors and process measures would make sense for that future project. I'm going to float around and do the same, as will Lisa and Tabitha. And I think those are all the specifics at this point. So same drill you've been through, many of you several times now, but again, we're looking for mainly an emphasis on the P portion here, the planning phase. If there are some due steps that you can get to before the breakout session ends, even better. We'll come back as a group at the tail end of this hour and ask you each to report out a real quick 5-minute summary of what your plans are for the next PDSA. We'd like you to focus attention on the referral network partner, obviously, that you're going to select for your next PDSA. A SMART aim, if you could be drafting a SMART aim, even if it's not fully fleshed out yet, we would like to hear about that, and maybe even some version of your change theory diagram.
Now, I won't be floating around because I'm going to be in the room with LCDA. Andrew's going to be with CAP Tulsa. Andrew can't be in 2 places at once, and so Adam has agreed to work with North Care, so he'll be joining you in your room. Yachi is coming back to MIECHV, and she's going to be working with Parent Promise. And Shaolan works with Tulsa C1, but she was out of town today, and so Tabitha is going to be working on the PDSA with Tulsa C1.
Okay, thank you for that detail. Well, then I'm going to be the one bouncing around and
Yes.
in and out, posing some questions here and there. But friendly reminder, we would like you to select a different referral network partner for the subsequent PDSA than the partner you're currently focused on. Timeline, this is important. Sorry, I skipped this step. So the PDSA that you've presently developed, all of those are going to start next week. Some of you have actually already started, and you'll continue to work on that until the end of November, early December. We have a learning session that will be scheduled Oh, I should have looked at this before I jumped back on the call, but I think it's January. Is that right, Lisa?
It's in January usually.
Yeah.
Yeah.
I didn't know which Lisa you meant.
Either, Lisa. So we'll be back together in this fashion in early January, where you will tie a bow on the PDSA that you're going to start in this breakout session, and then you'll leave that learning session ready to go and work on that particular project.
Now, if I could just put you a little bit on the spot, David, we're going to continue to collect data on the current PDSA that you already have in motion, because we haven't gone live, and so we're going to be doing that through the fall. And there was some question about whether we were going to end that at the end of November or the end of December. And I had emailed you about one of the programs making a pretty persuasive argument for not starting a new one in December because of the holidays. Were we going to start the new one at the 1st of January?
Yeah, so we'll start after we leave that next learning session, which ought to be early January. Yeah, no, I thought it was a great concern, and we were sort of debating that internally ourselves. So we're
okay.
And I think starting the new year with a new PDSA makes a lot of sense.
Okay, and that's the one we're going to work on today.
You're going to start it today. We'd like details about your plan. If you have extra time in this next hour and you want to start working on the do steps, that would be great too. Particularly screening information, that's often an ingredient of your do steps. So if you want to start thinking about how you're going to screen for this other referral network partner, and then communicate that information internally and then externally, that would be a wonderful target for this breakout session as well, if time permits.
This is the blank PDSA form. I've distributed this to the analysts and told them where I'd like for them to save it on our drive. And just because it's blank, they may not know some of the things to fill in. The home visiting agency you're working on will go under program name. This will be for cycle 2 starting in January. The primary driver is continuing to be the Unitas Care Coordination Portal, and we could get into greater detail based on the key drivers diagram, but that'll be a good placeholder. You put your name here or the name of the analyst who you're standing in for. So Tabitha is standing in for Xiaolan, so she'll put Xiaolan's name there. We'll start this January 24, and we can fill in the end date later. And I'll go ahead and distribute the key drivers diagram again, so you can be looking at that. But I think we all know where we're going here is to start talking about what you would like to do with the referral partner, and then you can start developing your SMART aim. I will email the analysts a place where a blank change theory diagram is available if y'all would like to work on that. So now, Lisa Tunley, if I can turn it over to you for the breakout rooms.
Yeah, are we doing 60 minutes or 90 minutes?
I think we're doing 60 minutes, aren't we, David? Are we doing 90 minutes?
Started right at 2:15, so I think if we can get it to end at 3:45, that's when we'd like the 5-minute presentations to begin.
Okay, so yeah, let's say come back at 3:45, and that'll allow a break at.
Can you hear me?
Yes.
I have a question.
Okay.
I don't understand the start and end dates that you were typing January 2024.
Okay. Well, right now we're continuing the first action phase.
Okay.
We had hoped to have it completed by now, but because we don't have everything live on Unitas, we're actually going to start it now and go to the end of the year. And so the next action phase will begin in January of 2024. So even though we're working on a new PDSA, we're months early at that.
Okay, okay, got it.
Does that make sense?
Yes, thank you.
Okay, good question. Other questions for us before we go to the breakout rooms?
And just a little bit more clarification on that. So we're on a condensed timeline relative to our previous learning collaboratives. You're going to get close to 6 months on this current PDSA starting in August and then going through December. But for the next two that follow, before this project ends, and this project is officially over September 30th, 2024, it'll be more like 4 months for the two subsequent PDSAs. So the one that you're starting to design today, if it matters at all, you'll have about 4 months to be concentrated on that particular project before you move on to the third and final PDSA, where you'll get another 4 months to work on that project.
Dr. Barr, let's think that you have a situation that you would like to start that earlier. And it doesn't matter if it's overlapping. I mean, it's at the end, it's utilizing Unite Us. Is that possible? Or you will have to wait until January to start doing those referrals, let's say to LAS.
I'm not opposed to that. How about we talk about that in the breakouts when I join your group? Anyone that wants to start early, we can sort of go through the pros and cons together.
Okay.
Okay, are we ready?
I think we are.
Okay, so I
Thank
have
you.
it set for 75 minutes. That'll put us a little bit before 3:45. So if we need an extra couple of minutes, I'll extend it extra couple of minutes, but that's 75 minutes.
Did I get
Okay.
the time? Was I right on the start time for the presentations, Lisa Deshay?
Yeah, it's we'll see how it's going. You know, you'll be in a room and you may see if people are finishing, there's no reason to drag it out, you know, to have the day longer for you, but we can be a little flexible on that. We were kind of aiming at 3:45 to start the presentations, but if everybody's done earlier than that, we can move that up.
Okay, sounds good. Yeah, I would say if there's time remaining, maybe focus on, as I said, the do steps and the outcome, the process disruptor measure. It's on the list, obviously, but those are things that tend to take a while to hone. So if you want to begin that process today, that would be fantastic.
Thank you.
Okay, I'm going to open the rooms.
Thank you, Lisa.
Make sure we're at 75 minutes. If you need me to put you in a room, just let me know, but you should be able to click on your room and go in there.
All right, who's next?
I can go next, but can someone share our form with me?
Who was your analyst in the meeting?
Adam.
You want me to email it to you, or do you just want me to share my screen right now?
Yeah, if you can share your screen, that'll be fine.
Okay.
Thank you.
You might email it to her later, though.
Okay, the Safe Care program at North Care, we decided to use Lasso. And so our smart aim is that 90% of Lasso referrals are connected to legal assistance that qualify, and that 90% of Lasso referrals are also accepted by, so basically looking to make sure our families follow through with the referral and that they meet the requirements needed for Lasso. So process measure, we're going to be looking at the percentage of accepted referrals that Lasso received and the percentage of referrals that Lasso accepted, comparing those two. Disruptors that we came up with was difficulty scheduling an appointment, just overall conflicts of scheduling, whether that be connecting by phone or actually getting the interview completed. An ability for Lasso to reach out to the participant, family changing mind about the need of Lasso services, and possible conflict of interest. So basically looking at things as disruptors, as things being the family also not meeting qualifications, because through the process and us talking, we know that there have been times where maybe there's been a conflict of interest or something, so they didn't qualify. Who will be implementing it are the home visitors. The targeted change is any participant needing legal services. So we're going to be looking at any of our consumers that have a situation that can benefit from those services. We'll be using Unite Us to refer to Lasso. This will be happening in the office or at the home with the family. And when will the activities happen? After the client has received legal services. So our to-do is provide the training for our providers on Lasso. We have new providers, making sure everyone's up to date, knows all the services that they provide, so we can be well informed when telling families about it. Also providing the family with a Lasso flyer at intake and having a conversation at intake to see if there is any basic needs or any needs for legal services. We also added at the very end, which didn't make it to this, is that we're going to do within the first 30 days, we're going to do the iHelp form with the family to assess their need for services also. So even if they're not reporting it at intake, we'll be doing that at 30 days and possibly doing it again like in a quarter. We're going to use Unite Us to make the referral and provide communication if needed between Lasso and the family to ensure that they connect to services.
All right, very good. Thank you, Dwan.
You're welcome.
That's terrific. Any questions for Dwan about their plan? Okay, who's next?
I can go next. This is Katie with Tulsa C1.
Great, thank you, Katie.
You bet. Give me just a second here. And all right. Looks like that's visible. Are you seeing that?
Yes, ma'am.
Perfect. So we last time did Lasso, so this time we elected to do some focus on Sooner Start. So we chose the change number 9, which indicated to make referrals based on assessment results that reflect the social determinants of health addressed by referral partners. So this change idea was important to us because Children First, one of our outcomes focuses on child development and child health. So our SMART aim is to refer 100% of children with identified risk of developmental delay per our ASQ scoring guidelines to Sooner Start via the Unite Us platform. So we plan to use an outcome measure using the ASQ administration results. We've listed here the required ASQs that we implement in our program, but we plan to screen using because they go every 2 months, we'll be able to screen each child once during that period. Process measure the percent of child or the children screened with the ASQ in that review period. A few disruptors that we've noticed or that we've thought of so far. So the percent of families who refuse the screening, percent of families who refuse a referral after screening has been completed and a referral is indicated. Missed visits. So therefore, if they've missed or didn't have a visit during that review period, then we wouldn't be able to have that data. And then the percent of families that have already engaged or already enrolled in the Sooner Start program prior to this review period. Tools to create, we have a few different things that we've listed here. So all of our nurses are already trained in the ASQ administration of the screening. But if we did have new nurses, that information, updating staff on the need to administer the ASQ to all children in that period, like I said previously. So those are the time frames when we normally administer it. But since the ASQ is a tool that's available for every 2 months, just updating staff that we can update or we can administer this every 2 months or availability to administer it frequently if needed. And then to schedule additional training via office hours. We had some questions and a little need for education related to the custom form on the Unitas platform for Sooner Start. And so we have a plan to connect with Kayla to get more education and support on that. Our plan is that Children First implement this when a child of the client is identified with risk for developmental delay. We will screen the child with ASQ and refer to Sooner Start via Unitas if it's indicated per our policy. It will be completed during home visits and then completed during the required time points or the additional ones if a required time point wasn't, if it wasn't time for a required one during that review period. Let's see, on our due portion, update staff on ASQ administration change, complete additional Unitas training, and then to utilize our existing system for tracking referrals. And we've had some conversations about what that might look like, but that's still an uncertain piece in our project.
All right, that's great.
Thank you.
Any questions for Katie? Okay, thank you, Katie. And who's going to speak on behalf of Parent Promise?
I can speak. It's Courtney.
Hi, Courtney.
I might need Alicia to share it for me.
Okay, Alicia, can you do that, please?
Or if our analyst can share the updated one, that would work too. I know Alicia isn't feeling well, so she might have stepped away.
Oh, that's right. Okay. Okay, Yachi's sharing it.
Perfect. Thank you.
Sorry, I shared the wrong one.
Oh, okay.
Thank you. Our smart aim, or we chose Lasso to refer to Lasso. And so our smart aim is through the Unitas to ensure a 3% increase in referring to Lasso. And our outcome measure is the proportion of families which needed Lasso referred to Lasso via Unitas. PEs will screen families twice a month at each visit to see if they need Lasso services and if they needed, how many of them use Lasso services. Process measures the number of were completed screenings if they haven't referred to Lasso. Some of our disruptors could be that You know, when we go to the visit or confirm the visit and they cancel, so we aren't able to get the screening in, or they leave the program. Tools to create or resources to prepare, a release of information, a script for following up with the families. So plan who will implement the change, the PEs, who is targeted for change, the enrolled families. I don't think we answered what will you do. Where will activities take place? In family homes during visits or virtual visits, and in office with Unite Us. When will the activities happen during and after home visits? For due, PE will schedule home visits with families. PE will screen families during the visits if the family already receives the service and don't need to do the screening. PE will enter the screening in ETO. PEs will enter referral in Unite Us if needed. PE will follow up with Unite Us in a week, and PE will follow up with family in 2 weeks and or next visit. If you can scroll down, please. Thank you. Oh, and that's it.
That was it. All right, great. Thank you, Courtney. Any questions for Courtney? All right. Thank you so much, Courtney.
Yes, thank you.
So we've done a lot today, and I think it's gone very well. David, would you like to? I just wanted to share one thing real quickly. I had found this article that I think might have some information you would be interested in. And it has to do with gaps in knowledge about things like do pregnant women needing to get a whooping cough shot, and who knows, other information about vaccination, who's at risk for the flu, and what shots are not recommended, and so forth. Would this kind of information be something that would interest you to receive?
That would be wonderful, Lisa. Thank you for showing and sharing that.
Yeah, you bet. I'll go ahead and just drop this in the chat. And David, if you would like to take it away.
Yeah, no, I mean, that's a great way to end, right? It's a learning collaborative, emphasis on learning there. And we learn from each other. I'm really excited. I know I'm gonna sound like a broken record. I think I say the same thing or some version of this at the end of every learning session, but really excited to see where these next PDSAs take you, both those that are ready to fire away next week and then the ones that we're scheduling now for January. Got a chance to hop into every single room and hear bits and pieces of what you have planned for the next one. Was really moved by some of the stories that were told about excitement for what's ahead and these new partnerships with referral agencies and particularly the LASSO agency and PCAP. Just knowing what limited resources have been available in our communities historically. So as they say, it does take a village to pull these things off. And this is, I called it the white whale at the beginning of today, this idea of closing the loop and exchanging information bidirectionally. I don't think it's a stretch of the imagination or truth to say that we've kind of dreamt about this happening for ages now. And we've had some clunky versions of it that we've tested in the past. But we are on the doorstep of being able to do this at our fingertips. It's not going to be perfect even a year from now after we've had 12 months experience. I'm sure there'll be things that we want to fix, but just having the opportunity to participate in this pilot project and the hope that it's bringing has certainly brought me some joy. I hope it has to you as well. We're here to help. We're here to facilitate, particularly for these new PDSAs that you've just started to piece together this afternoon. Some of you are going to be referring to LASSO for the very first time, and the few rooms that I hopped into, you were having these initial discussions about screening instruments. We'll help to the extent we can sort of share information from the other sites that have gone before you. You've got wonderful resources at LASSO. Pilar was on this afternoon and providing some of that direct input. But please do not hesitate. Just buzz us, let us know if you need more support there. Same is true for those that have agreed, and thankfully, CAP Tulsa, really excited about your project with PCAP and sort of being the guinea pig for all of us there about that screening process and using Unite Us to make those referrals to this exciting new program in both Tulsa and Oklahoma City. But let us know how we can help. We've got wonderful supports from the PCAP program. Happy to hear they're going to be on site tomorrow. You saw the presentation that Dr. Fleming gave this morning with the uncope measure. I can tell you that this is one that PCAP advocates using. So if we can be of support there, just let us know. And yeah, we're off and running. I don't know if Kayla's still with us, but Kayla, you are a fabulous teacher, as was relayed to you earlier today. And we're really fortunate to have you as a partner in this. And thankful for the Unite Us organization and their flexibility in adapting to all of the various needs and requests of this project. I got to say, we've had a number of third-party contractors in the past where we've made sort of these wish list items, and typically the first answer we get is no, and then we pester them until they cave, which sometimes they do, but not always. With Unite Us, it's been very different, and you know, we make these wish list item requests, and rather than say no up front, if the answer is not immediately yes, it's that, you know, let's think about this and try to make something happen, even if it's a compromise. So really thankful to have them on board and to finally get through all that contractual logistics or gymnastics that we had to play for several months there. I think we've reached the end of the agenda, unless Lisa, we have other things we need to relay.
I don't think so. I was going to thank Lisa Tunley for everything she does behind the scenes, and the analysts for jumping in with the breakout rooms, and Tabitha for her terrific work, and to Pilar for always being a great partner and being willing to jump into our breakout rooms and help as she could. And so we're looking forward to it. And thank you, everybody, for your time. Y'all have a good evening.
Goodbye, everyone.
Bye-bye.